My name is Nancy Dunch, and I'm a physical therapist and an instructor here at Waukesha County Technical College. Today we're going to talk about moving, transferring, and ambulating, that is walking, your residents safely. We want to be able to move them safely in order to protect them from any injury, as well as to protect you from any back injury that you may occur. We want to keep the residents moving for several reasons. We want the psychological benefit of keeping their independence as high as possible, as well as to keep them independent in order that you will not have to do as much work and strain your back. In addition, there are a number of physical benefits also. The physical benefits would include having your residents keeping their cardiovascular status, pulmonary, circulatory, and bowel bladder functioning. There's some things we first must consider prior to moving your residents. First thing to remember is that you must take your time. When you rush and move a resident around, it is perceived as being an uncaring gesture, as well as your risk of injury for both yourself and the resident increases. In addition, you want to make sure that you have ample room to maneuver not only the resident but also yourself. You'll be sticking with them when you are walking with them very close, and you need room for two people. So the furniture needs to have some room in between it so you can accommodate both of you. You want that the equipment be regularly inspected for wear. The tips of assistive devices are considered to be non-slipped. However, when they're used for years on end, the rubber does wear away and it becomes slippery. So they need to be inspected regularly and changed when they do wear out. These can be purchased at any number of drugstores, and they are just easily pulled off and stuck back on at the bottom. You want to make sure that the area that you are going to be walking a patient is clear from things like electrical cords, area rugs or loose mats, litter, debris, and water. You want to make sure that you have brought any equipment that you are going to need with you at the time prior to standing the resident. There is nothing more uncomfortable than standing a resident, getting them up, and realizing that the walker is over on the other side of the room. And now you have a safety issue. So you want to make sure you bring that at the time prior to rising them from the chair. You also want to make sure that you are mentally and physically ready to do the activity that you are going to do, both for yourself and the resident. You want to make sure that their clothing is secure, their shoes are tied, and that you have mentally prepared yourself for any unforeseen circumstances such as falling. First thing we must consider prior to moving a resident is your body mechanics. So we're going to view some of the basic principles of body mechanics. Body mechanics are very important for yourself, not only to conserve energy, but also to reduce your chance of injury, specifically the strain that you would occur on your ligaments, muscles, and joints. Also, using proper body mechanics will maximize your strength, and therefore the wear and tear that your body takes will be less. Some simple principles of body mechanics are first to remain close to an object. In this way, it's similar to carrying anything else. If I were to give you 10 pounds, you would probably not hold it way out here, you would hold it here. Because out here would require a lot more from you. It's the same when you're doing any kind of transferring. You want to keep the resident and anything else that you're moving close to your body or your center of gravity in order to maximize your strength. You want to also keep your feet apart. When your feet are next to each other, it's similar to having a pyramid balancing on its tip. You're not stable. So you want to keep your feet far apart so you have a stable base on which you can be maneuvering. You want to stoop or squat to lift and not move simply at your waist. You want to make sure that when you are moving, to pull just at the waist increases a significant strain on your back. Your back posturing should be at a lordotic posture, which is a curve that faces anteriorly or forward. So when you go to lift anything, the feet are far apart, you are moving your legs, and you're keeping this curve that is facing forward the entire time, up and down. It's easy for people to remember going down, but for some reason or another, they want to lift their seat up first, and then they become this arch. When you arch in such a way, you end up increasing the disc pressure themselves. You end up taking the muscles back to this stretched out posturing that we already spoke about, and we also end up putting the pressure on the weakest ligaments of your back. In addition, you want to make sure that you are not twisting at any time while you are lifting. Twisting and lifting increases the chances of injury significantly. Whenever possible, you should push or pull or roll or slide an object, if at all possible. We'll now review those principles of body mechanics. Number 1, remain close to the object. 2, keep the feet apart. 3, stoop or squat to lift. 4, maintain that lordotic posture. And 5, avoid twisting your body when you lift. Now that we understand body mechanics, we're going to take a look at transferring a resident from a chair or from a bed to standing. This can be accomplished safely if done correctly. It is important to have the resident participate to the best of their ability. This way it encourages them to keep their independence as well as less strain on you. The first and foremost thing that we need to consider with transferring is the safety belt. We will now see a demo on the proper use of a safety belt. Now we'll take a look at securing a safety belt. You'll notice that the clasp has a side that has teeth on one side and smooth along the other. You'll want to take the end and place it into the side that has the teeth first. Pull it so that the teeth will rest into the belt. Take the end of the belt and put it into the other hole so that it is covering the teeth. And you will pull it snugly. If it is too loose, you will push it from the first end past the teeth and then through the second. You want it to fit snug so that it is not suffocating, but yet you can fit 2 fingers between the body of the resident and the belt. Now let's take a look at putting the safety belt on a resident. We placed our resident in a stool so that you may see around the back, understanding that you would normally be doing this in a chair with the back. First we'll take the belt and place it around their waist. We then want to take the end and again put it into the area with the teeth first. Pull it so that it's snug and the teeth are against the belt. We then are going to take the end and put it into the second hole and pull. We now want to check for snugness. If I were to leave it at this, when we go to transfer, this would slide up her torso. So we want to make sure that it's snug. So we pull first here and then secondly at the end. The end can be tucked into the belt so that it is not free and will not get caught on something. Now that we have the belt snug with just a 2-finger width between the torso and the belt, we can now transfer the resident to standing or to another chair. Now that the belt is securely placed, we need to instruct the resident as to what is going to occur. We want them to participate as fully as possible, and so they need to have specific directions as to what they are going to do. We will now take a look at a demonstration on transferring. Now we'll look at standing a resident. First thing we're going to want to do is move the resident to the edge of the chair or the bed. By doing this, we can have them kind of wiggle to the front. So what we're going to do is have the resident sit upright, and now you're going to take the weight off of one hip by leaning to the other side and move that hip forward. And then shift the weight to the other side and move that hip forward. Once they are to the end of the chair, we're going to have them prepare for standing. The things that we need to consider are feet flat on the floor. Remember, good shoes, nice non-skid shoes. Next, we're going to want hands on the chair or the bed to help push up. We do not want the hands of the resident at any time on you. That makes it unsafe for you and for them. Another thing to remember is to make sure that you have told the resident what we are going to do and what participation you want them to do. What we want to tell them is that we're going to stand, and their participation is twofold: knees straight and hips forward when I tell you. So what we're going to do is put our hands on the safety belt, have the resident lean forward, nose over the toes, and stand. Knees straight, hips forward. Once you are fully both standing, you can then pivot or begin ambulation. In sitting, it's just the reverse. You want to back up to the chair till they can feel it at the back of their legs. The hands, as we sit, are going to go to the chair, not onto you. So we're going to slowly sit down, controlling the motion all the way down. So we're going to go ahead and sit down, hands towards the chair. Once the resident is safely placed in the chair, you may then stand yourself. Remember, always watch your body mechanics throughout standing and sitting. Let's review the transferring points that we just discussed. Number 1, use the safety belt. Number 2, instruct the resident as to what they are to do. Number 3, move the resident to the edge of the chair or bed. Number 4, have the feet flat on the floor. Number 5, have the resident stand up using hips forward, knees back. Number 6, pivot after the resident is fully standing. And 7, slowly lower the resident down to the seat. Now that we have the resident up, we can start thinking about moving them from place to place. It's really important to keep your residents moving. We spoke about the physical benefits and as well as the independence thoughts. How much they move is not the issue. It's the fact that they keep moving. So even if it's a short distance, that's fine. We'd like to see if the resident is only moving a short distance, that they have a chance to walk several times during the day and not just be sitting the entire day. When beginning to look at ambulation, we want to watch for weight restrictions, specifically following a surgery. Frequently after surgeries, doctors will insist on a certain type of weight restriction, whether it be partial weight bearing or non-weight bearing. That needs to be considered each and every single time that patient or resident is being moved. Again, we want to make sure prior to start walking a resident that the area is free from loose rugs, electrical cords, or other things that the resident may trip on. We want to make sure that the resident has proper shoes. That is, shoes that are securely placed on their feet and are flat. Slip-on slippers do not qualify for proper shoes. They need to be shoes that have a non-slip surface on the bottom and preferably that are tied. If they do not have them on their feet, you need to go get them, because walking them without this is an extreme danger. We want to make sure that any assistive equipment that is being used is fit for that particular resident. The equipment does not come as a one-size-fits-all. They're easily made to fit each and every person, if just turning them upside down and pushing a button. When guarding your resident, you want to make sure, of course, to be using a safety belt, as well as the side that you want to be standing on is the weak side. You want to be standing slightly to the side and slightly behind them. This way, in case they would lose their footing or fall, you can safely help them to the floor. In addition, before walking, you want to know the distance that you're going to be walking and if there are any rest spots or chairs along the way, so that you can plan for any unforeseen circumstances. The first way of walking that we're going to discuss is called standby assist. This is for a resident that is not using an assistive device but may need a little extra help from getting from here to there. Sometimes residents normally walk independently, but after a flu or a bout of illness, they may be weaker and need some extra help. Standby assist is perfect in these situations. And of course, you want to be using the safety belt, explain what is happening and how far they are going to be going, and know the distance and if there are any rest spots or chairs along the way. Let's take a look at how you would help guard a person with standby assist. These are for those times where a resident may have had a bout with illness, such as the flu, or maybe after minor surgery, and they have now returned to the facility. First thing we have done is we've placed the safety belt on, and we are going to take our hand in the middle of their low back, come from underneath the belt, and securely hang on to the belt from behind. With standby assist, we can offer our second hand to the resident for them for further stability. When walking, you are going to guard from slightly behind and to the side. The side that is best to stand on is the side that is considered to be weaker. When pivoting, you want to be sure that you are pivoting in a semicircle and not pivoting on a dime. Pivoting on a dime decreases their stability and therefore puts their balance at risk. We are now going to take a look at using the stairs. When ascending or descending a stair, which foot goes first is crucial. When ascending a stair, you first want the stronger or the good foot to go first. So when going up, it's the stronger foot first, the weak second. When descending, it's just the opposite. The weak leg goes first and the strong second. A way to remember that is when ascending, the good goes to heaven, and when descending, the bad goes to, you understand. Now that we've seen how to help somebody with standby assist and how to go up and down a step, how about the times where that patient has been ill or had a bout of illness and is weaker? What do we do about falling? Let's take a look at what that might look like. Remember, following a bout of illness, such as the flu, stability may be a problem. When walking down a hall, the resident may use the wall as a support. You should be standing on the weak side and guarding them in that fashion. When the resident begins to fall, do not try to hold them up. Lean them against the wall and lower them to the floor. Holding the resident up puts both the resident and you at risk for injury. Be sure to watch your body mechanics as you lower the resident to the floor. Now that we've seen how to safely help someone during a fall, what about using a walker? A walker is used for stability. It offers a great amount of stability, probably the most stability of any assistive device that we have. The important thing to remember with walkers is that all four legs must be on the floor at the same time. It is not a 2+2 type of a device. The walker needs to be placed in a comfortable position ahead, one that does not require bending at the waist from the resident. Of course, we would again be using a safety belt at all times, explain what is happening and how far the resident is to go, and if there are rest spots or chairs along the way. We want to continue to watch our body mechanics throughout the entire time. Let's take a look at ambulation with a walker. In order to fit a walker, you first want to take a look at the handrest to what level it is occurring. We want the handrest to be at the bend of the resident's wrist. This is obviously too tall. So we will take the walker, turn it upside down. All four legs have a little button in which you will push, turn, and wait for the pop. Make sure it's secure. And then chuck it. Do that on all four legs. Fitting a walker is sort of a trial and error. So you fit it so that all four are at the same level, and then try it again on the resident. At this time, and it's a very good time to take a look at the tips on the bottom of the walker to check for wear and to make sure that they have remained non-skid. We then will check it again and see that the handrest is at the bend of the wrist. Another way to show it is that when the hands are on the handrest, that we have a 20 to 30 degree bend at the elbow. Now to begin walking with the patient, you of course have placed a safety belt on. Your hand is securely in the middle of their back. In order to advance the walker, you want all four legs to hit securely on the ground. You do not want to be doing the 2+2 where you have put two legs, have them start walking, and then the other two, which puts them in a balance deficit. So to begin walking, we'll put the walker forward at a comfortable position. There is no waist bend. Once the waist bends, you're putting it too far ahead. And then the resident will take a step with the weak leg and then the strong. And at that time, move the walker again. So there are 3 steps: walker, weak leg, and then strong. And again, walker, the weak leg, and then the strong. You as an assistant will be standing slightly behind and on the weak side. Now that we've seen how to use a walker properly, what about a cane? A cane offers less stability. The cane should always be used on the unaffected side. That would be the side that it would be considered to be stronger. This is important that the weight be transferred to the strong side and used on the strong side as opposed to on the weak side. It is also assists in keeping an upright posture. We don't want to add a poor posture to an already ailing body. Let's take a look at walking with the cane. Much like the walker, we want the hand rest to be at the bend of her wrist. This is too tall. With this particular cane, there is an area that needs to be, nut that needs to be unscrewed first. We push in the button and pop it in and tighten at the bottom. With a quad cane, we have 4 legs. The legs that are straight go next to the resident, and the ones that stick out to the side go out to the side. Okay. We're going to be using the cane on the strong side, and the guarding where you will be standing will be on the weak side. When walking, you will first have the resident advance the cane first, and a short distance. If it is too far, it will again put them off balance. Then it will be the weak leg, and then the strong leg. And the cane, weak leg, and strong leg. Once they become proficient, they can then use the cane with the weak leg at the same time, and the strong leg second. So that'd be cane and weak leg, and then the strong leg. Again, you will be guarding from the side and slightly behind. Now that we've seen ambulation with the cane, what about crutches? Crutches are an assistive device that requires a fair amount of muscle coordination, balance, and motor control. Fitting of a crutch is crucial. At no time should one rest their armpits on the top of the crutch. There are nerves and arteries that are very superficial at this point, and they can be impeded. This would cause something called crutch palsy, in which the resident would lose function of their hand. Let's take a look at fitting and walking with crutches. With the crutches, it's a little more complicated for fitting. It is important to note the majority of your residents will have already been fitted properly by the professional that prescribed the crutches initially. What we are going to be looking at is 2 things. One is the height of the crutch. The height of the crutch should be such that when it is placed underneath the arm, that there are 2 to 4 fingers that can fit between the top of the crutch and the armpit. This is too tall. To change it, we have the same push button mechanism, and to pop that in. The second thing, now that we put this back, we'll then take our 2 to 4 fingers in between the top of the crutch and the armpit, and in this case we can get 3 fingers in there comfortably. The next thing we will check is the hand rest. Again, we are looking for it to be at the bend of the wrist. This requires actually a nut and bolt type thing. If you take out the bolt and just slide it up, and then place the bolts back in. And we'll check that. Oops, at the bend of her wrist. So when she puts her hand on it, we have a 20 to 30 degree bend at the elbow. When using crutches, it is important that at no time would the resident be resting their armpit on the top of the crutch. There are very superficial arteries and nerves that will then become pressured and can become damaged, which would mean loss of function of the hand. So anytime using the crutches, the top of the crutch pad is not for the armpit, but for the torso and should be pressed against the torso at all times. We've placed a safety belt on and are grabbing in the small of the back. In order to sequence this, we will want first the weak leg to move, squinch the crutches close to the torso, move them forward, and then the strong leg. And again, weak leg, then the crutches, and the strong leg. At no time during walking or standing should the resident at all be resting their armpit on the top of that crutch. Remember to watch not only your body mechanics, but also the residents throughout ambulation. We've now seen safety and guarding with transferring, walking without assistive device, as well as with a crutch, cane, or walker. Remember to plan out your task, use your head, and take time for a safe activity, whether it be transferring or ambulation. I hope you gained valuable information to keep both yourself and your residents safe and free from injury. Thank you for your time.